Hello everyone. We'll just wait a few more minutes before we get a few more attendees, and then we'll kick off. So I'll mute myself, give it another minute, and then we'll start. Okay, so 2 minutes past 12. I think we'll start there for everyone. So thank you for joining. This is part 2 of our ERA webinar series. For those that didn't manage to watch our first webinar last month, don't worry, because we will be having a bit of a recap of the previous session. We'll be starting with that. Part 1 focused on who should be using ERA and the importance of referring the correct patient population. Today's part 2 will be focusing on the importance of ERA protocol compliance. So that's in order to optimise patient outcomes. So I'm Kate Gresty, for those that don't know me. I'm UK and Ireland Sales Manager at the Vitrolife Group, and I'll be moderating today's session. So we have 3 experts on our panel today. First of all, we have Dr. Laura Gerardi. So many of you will have heard from her in a previous webinar that she did part 1. So the bio should be shown on screen now. Laura is our Head of Scientific Support at Igenomix at the Vitrolife Group. So Laura manages a team of scientific advisors and also genetic counsellors right across the EMEA. This team forms a unique support service, which is, again, unique to Vitrolife Group. So customers can always access this team, and I think it's very invaluable to note that. Secondly, we have one of our local UK experts, Elizabeth Verdon. So Lizzie's bio is shown on screen now. Lizzie is one of our scientific advisors, so supporting all of our genetic services and part of Laura's team. So Lizzie is a very experienced genetic counsellor with Igenomix, part of the Vitrolife Group, and specialises in reproductive genetic services. We are also joined by Maria Ruiz, so bio again on the screen. So Maria is ERA Clinical Manager at the Vitrolife Group. So Maria has over 11 years of clinical and research experience and has published several scientific journals listed on screen. With her extensive background in the ERA test, Maria will be joining us for the questions section of the webinar, and she'll be on hand to answer any specific questions that anyone may have. So for housekeeping, can I ask that any questions you have be written into the little question box on the right-hand side of the screen? After the presentations, I'll direct these questions to the experts that we have on the panel. So nothing will be interrupted as they're speaking. We will ask them towards the end of the session. So we do only have 15 minutes for the question and answer section. Anything that we don't get to or any questions outstanding, we will collate them, we'll send them round, and then we will contact you via email with the answers. So we will make sure that we answer everything. And I think that's everything. So I shall hand over to Laura.
Yeah, thanks, Kate, for the kind introduction, and thanks to all of you for joining us in this part 2. As Kate was saying, in the first part of the webinar, we focused on who should be using ERA and the importance of referring the correct patient population. So I will have a brief recap of part 1. So very briefly, what we saw is that the window of implantation is a short period of time between 12 and 48 hours when the endometrium is receptive to embryo implantation. And this window of implantation usually occurs between day 19 and 21 of the menstrual cycle. Now, in a typical hormone replacement therapy cycle, most women show receptivity after 5 full days of progesterone exposure. And so what we always assume is that the window of implantation is constant in all women. However, not all women respond to progesterone in the same way, and they can, demonstrate receptivity in different days. So some women have a displacement needing more additional time of progesterone exposure, and we refer them as pre-receptive. Whereas others need less exposure time, and we refer as post-receptive when the window of implantation has already passed. We saw that if embryo transfer occurs during the standard window of implantation, but in women with a displacement, then implantation failure may result. So we believe that the identification of this endometrial window of implantation in the clinical setting should enhance IVF fertility treatment outcomes. How can we do it? With our ERA test. we saw that endometrial receptivity analysis is a unique test able to determine each woman's unique personalized embryo transfer timing. Today, we perform it with next generation sequencing, meaning that we are able to measure the gene expression of these 240 genes, which we know are involved in endometrial receptivity. And in particular, after sequencing, we have a computational predictor that is able to classify the endometrium in receptive or non-receptive. Finally, you will get a results coupled with a recommendation for personalized embryo transfer according to your patient-specific endometrial gene expression profile. We talk about evaluating ERA as a potential add-on in fertility treatment, and in particular as a tool of precision and personalized medicine. So we believe it's important in this context to evaluate two main aspects. First of all, we should be using ERA, so in other words, which is the population of interest. And secondly, which are the important outcomes of interest, so which are the objective of the test. So in the first part, we went through the main evidence we have regarding the benefit of ERA in a specific patient population, which is not all fertility patients, but is repeated implantation failure. And we saw the appropriate outcome measures that should be evaluated. So basically, what we saw is that recurrent implantation failure is the initial indication for ERA. And the reason for this is that the risk of having a displacement in the window of implantation is higher in patients with repeated implantation failure compared to the general population. And in general is around 30%. So this means clearly that we have an increased risk of transferring the embryo in a non-receptive endometrium. On the other side, we focused on the objective of the test, that is specifically enhancing implantation. And this is possible thanks to the synchronization between the implanting embryo and the receptive endometrium. So the correct outcome measure for ERA test is implantation. And finally, this is what I will recap now, always in the context of evaluation of ERA as a potential tool for improving our outcome. Once we have identified the correct patient population, which is RIF, I'm going to show you some evidence we have regarding the clinical application of this tool in the proper patient population. And as you will see here, we have the highest published clinical rates for RIF patient compared to any other endometrial receptivity test in the market. In particular, we focused on two main aspects. These are the key messages we can extrapolate from the literature we have on ERA. First of all, patients with repeated implantation failure who underwent a personalized embryo transfer guided by ERA had significantly increased clinical outcomes versus those patients who did not undergo a personalized embryo transfer guided by ERA. And second concept, RIF patients who underwent this personalized embryo transfer guided by ERA were found to have similar outcomes to those achieved by good prognosis patients. So in other words, we are raising clinical outcomes of RIF patients to those expected for good prognosis patients. Now, as you know, this is a theme treated much worldwide. So in 2022, we published a revision on the literature in RBMO journal. But after 2 years, obviously now we have even more data and more articles published, more than 40 in general. In this, we can identify some strong evidence, for example, for meta-analysis. They were both on repeated implantation failure and good prognosis patients. We have also 2 randomized control trials, one internal and one external, but both on good prognosis patients. And more recently, we have also 1 prospective RCT specifically for RIF patients. So just to summarize what we saw in part 1, as far as meta-analysis, which is the best proof of evidence-based medicine, we saw that 3 out of the 4 meta-analyses available for ERA were in favor of ERA, showing a benefit specifically in RIF patients. We also saw that probably now with more data, new meta-analysis will show even more benefit. More recently, new evidence have been published. This should be definitely considered when evaluating ERA as again, and the effectiveness of this tool. Why? Because this is a high quality publication. As you can see, this is a prospective randomized control observational follow-up study, specifically including 320 patients with repeated implantation failure, meaning that they have previous failed cycles with euploid embryos. So in this typical study design, which is right patient population, randomization for ERA, corrected for embryo factors, so with PGTA. As you can see, we have the study group, ERA and PGTA, the control group, only PGTA, and a second control group, which is not advanced maternal age population. What we saw is that in the study, and the author concluded that personalized embryo transfer guided by ERA significantly improves ART outcomes in advanced age patients. Indeed, is more clear from the conclusion than from the table, but pregnancy rate, implantation rate, live birth rate were significantly higher in the study group, meaning PGTA and ERA, compared to control group 1, which is PGTA only. So this clearly highlights the efficacy of ERA in optimizing reproductive outcomes. And the author even added that in the study group, live birth rate was almost the double that of the control group. So there is a substantial improvement in outcomes through personalized approaches. Obviously, this is also a great indirect evidence that repeated implantation failure patients without the application of personalized embryo transfer guided by ERA have a reduced probability of achieved pregnancy compared to the group where ERA was applied. As opposite, we have commented also other studies. This is just an example, is the paper published by Doyle and her team from the US. This paper has been recently used as a reference to say that ERA does not provide a benefit. Which are the features of this paper? The study included good prognosis patients, and they transferred PGTA tested embryos. So they wanted to understand if there is a wider indication for ERA, so not just RIF. And what they found is that there is no benefit in applying in the general population, so not support the routine use. Actually, this is what we reported in our RCT, in which we didn't see a benefit in live birth rate in patient going to an IVF treatment at the first appointment. But I just wanted to comment briefly the reason behind this failure. And the reason is that the risk of a relevant displacement in the window of implantation in patients without repeated implantation failure is generally low. So this means that, and this is the majority of patients falling in this paper, the majority of patients were in the transition phase between pre-receptive and receptive status. So this means that if we have a patient or an embryo and we're transferring the embryo in this position, this embryo can naturally implant with the receptive endometrium. So it's clear that adding 24 hours of progesterone exposure does not provide a clear benefit. And this phenotype is completely different to repeated implantation failure patients. So this is just to say that we cannot translate the benefit expected for repeated implantation failure, which is far from achieving receptivity, to the general good prognosis patient population. Finally, we have also commented that it's not easy to design and collect data under a proper randomized control trial, and even specific for RIF patients. So at least this is what we saw from the literature. So obviously, are there other type of studies that we can evaluate to assess live birth rate, or at least indirectly assess repeated implantation failure patients and implantation rate, which is the proper outcome? Our answer is yes, in that we have numerous internal and external publications demonstrating the utility of ERA, specifically in the RIF population, and showing also significantly improved clinical outcomes when patients undergo personalized embryo transfer guided by ERA. So we have commented a couple of retrospective studies. This is just the first one I want to comment, is the paper from Jean et al. They included a total of 281 patients with repeated implantation failure, and they compare between personalized embryo transfer and standard frozen embryo transfer. What they found, and this is clear from the table, is that implantation rate, pregnancy rate, and clinical pregnancy rate were significantly improved when the RIF patients population underwent personalized embryo transfer guided by ERA compared to the conventional frozen embryo transfer patients. Again, another retrospective study. This is more recent, but again, we know the limitation of retrospective studies, but this includes a good number of patients, 1,422 patients with repeated implantation failure patients. Specifically, they included women who incurred at least 2 or more consecutive implantation failure in IVF ICSI treatment. Just to summarize the results, obviously I will not comment in immune profile tool, just the ERA group. But what we can see from the table is that the results regarding the 4 pregnancy outcomes indicator, biochemical pregnancy rate, clinical pregnancy rate, implantation rate, and ongoing pregnancy rate, were significantly higher in the ERA and ERA plus immune profile compared to no test group. So again, we have to consider this publication. We concluded that we have sufficient evidence and publication showing that ERA works in repeated implantation failure patients, but iGenomX is always committed to demonstrating the efficacy of ERA in patients with previous failures and continually improving our ERA test. So we have designed and we have ongoing a multi-center prospective non-selection study for endometrial receptivity analysis in patients with previous implantation failure, and we'll be happy to show you the results in the future. Finally, I just want to conclude with a couple of clinical consideration and limitation regarding in general the clinical application and the benefit of ERA in infertility in IVF patients, I would say. So first of all, we have to consider which population analyzed, which is the population analyzed and taken in consideration. As we saw, the ERA test is indicated in patients with recurrent implantation failure, where the rest of the factors, such as embryo factors, are ruled out. Why? Because this is the population where there is a greater risk of presenting a clinically relevant displacement. As I was trying to comment, clinically relevant displacement means this type of profile where we are far from achieving receptivity. This means that it's unlikely that if you transfer the embryo in this moment, that the embryo will naturally synchronize and implant in the receptive endometrium. However, or better, on the other side, this is a non-RIF patient, which is more close to the receptivity status. So adding 24-hour progesterone will not see, we will not see a clear benefit or improvement in clinical outcomes. However, we have also to consider, and this is important when we evaluate publications, the probability of pregnancy of repeated implantation failure patients is reduced, but it's not zero. Last clinical consideration is we have to take in consideration, at least when reviewing publication, not only when using our ERA test, that monitoring of variables to confirm reproducibility are mandatory. One of these, for example, is endogenous progesterone control, but also is also important to proper control over reproducibility in terms of protocol and endometrial condition. This is what Elizabeth will cover in the second part. Just want to conclude with another example of study with several limitations that was used as a reference against ERA. This is the famous Cozzolino paper, and these are the results that they have extrapolated in a certain period of time with the patient going to their clinic, so participating in IVF treatment in this center. What we saw is that, and what we can tell you is that these clinics also participated in our randomized control trial. So when we separated the results from the other, and when we consider only those patients who follow properly the protocol and when reproducibility of the results was guaranteed, the outcomes were in favor of ERA. So this is just to say we have significantly improved outcomes in personalized embryo transfer compared to fresh and frozen embryo transfer when the results are controlled. So this is just to remark that absence of bias and proper control of key variables leads to different results. So that's why in this second part, Elizabeth will focus more on how to ensure this proper protocol compliance in your clinic and amongst your patients for having superior clinical outcomes with ERA.
So thank you, Laura. So now for the second part, we're going to hand over to Elizabeth Ferdin. Lizzie, are you there? Perfect.
Hi. Right, hopefully you can see my screen okay. If someone could shout if you can't, but I'm going to see you can. Brilliant. Okay. Lovely. So thanks, Lara, for providing such a good recap of our first ERA webinar. Hopefully you've got a really good idea of what ERA is and the patient groups that it's appropriate for. So the remainder of this session, as Lara has already said, will be about protocol compliance and why this is so important in order to get the best outcome for your patients. So Lara presented a wealth of research in the first webinar by iGenomX and other groups that have demonstrated the clinical benefit of ERA. This is all very well in a research setting, but where everything's very well controlled in a research setting, but how do we achieve that same success in the clinical setting? So the key to this, as you probably guessed, is protocol compliance. And this is because with complying with the protocol enables us to achieve reproducibility. So what does reproducibility mean in the context of ERA? If an ERA result is reproducible, it means that that result, the result of the mock cycle, is actually relevant to the subsequent cycles. So you're actually transferring at the optimal time. And ultimately achieving this reproducibility means keeping everything the same between the mock and the transfer cycle. So in this session, we'll aim to cover the different variables that can influence reproducibility of ERA and explain how we can control those. So as you can see, there are a few different factors that do influence the reproducibility. First of all, we will start with elevated endogenous progesterone levels, which is relevant before the biopsy or before the transfer takes place. Lara's already shown you this diagram, but just a brief recap, you'll probably all know that progesterone is the most important hormone that influences the receptivity and the window of implantation. Once progesterone reaches a critical threshold, then the transformation to the secretory phase begins, and as you probably know, that's where we're going to find the window of implantation. Even really low levels of serum progesterone can trigger this transformation. So for this reason, we do recommend really regulating the endogenous progesterone levels and ensuring that they're below a certain threshold, which we set as less than 1 nanogram per milliliter prior to starting your exogenous progesterone, or in a natural cycle prior to the HCG trigger or the LH surge. This is so that we know exactly when that transformation to the secretory phase begins. If the endogenous progesterone is higher than this, then we don't know when the transformation started. It might already have started. And so this can influence the ability of the results from the mock cycle to be relevant to the transfer cycle. So what does the protocol say? It states that the endogenous progesterone must be properly controlled in the biopsy and transfer cycle, and it must be less than 1 nanogram per mil within the 24 hours prior to the first progesterone, that's in an HRT cycle, or at LH plus 0 or HCG plus 0 in a natural cycle. So both the level of progesterone and the time points are important here, and we need to see this control across the mock and the transfer cycles. So the common theme is keeping everything the same between these two cycles to achieve the reproducibility. Now we use this 1 nanogram per milliliter as a cutoff. It might be a little bit conservative, but even very small amounts of progesterone have been shown to initiate this transformation to the secretory phase. So we want to know exactly when the patient has exposure to initiate movement to the window of implantation. If we look in a bit more depth now, an HRT cycle, you can see the schematic here. The patient is usually on about 10 days of exogenous estradiol, and around about 10 days when we see that the endometrium is trilaminar and a thickness of greater than 6 millimeters, then we would check the endogenous progesterone to see that it's below 1 nanogram per milliliters. And then within the next 24 hours, we want to be starting the exogenous progesterone. If the progesterone level is more than 1 nanogram per milliliter, we do recommend cancelling the cycle and starting a new one. And this is because if we see levels above that threshold, as we've already said, we don't know whether that transformation to the receptive phase has already started, and that's going to affect the accuracy of our recommendation. So now looking at a natural cycle, when a patient has the LH surge, we would want to check the progesterone levels then to ensure that they're less than 1 nanogram per milliliter. Or if we're giving an HCG trigger, we want to measure again the levels on the same day. And again, if the level is greater than 1 nanogram per milliliter, we'd want to be cancelling that cycle and starting a new one. And again, we want this control in both the mock and transfer cycle. So just looking briefly at our TRF, it's quite an extensive form, lots of information required. And the reason is that we want to make sure that we help you to get a reproducible result, to get the best outcome for your patients. So on page 2, you'll find that there's a request for details about endogenous progesterone and a reminder that we need both the dates for measurement and the level. So let's now think about what happens if we don't control endogenous progesterone. So this is an example here. At the top here, we've got the mock cycle, and as you can see, endogenous progesterone has been measured according to the protocol and was less than 1 nanogram per milliliter within 24 hours of starting exogenous progesterone. The biopsy was then performed at 120 hours, and we got a pre-receptive result. So this means that the window of implantation is likely to be 24 hours later than the biopsy. So recommendation in this case is to perform the transfer 24 hours later, so 144 hours. And then you can see in the personalised embryo transfer cycle, or the PET cycle below, for some reason endogenous progesterone was not controlled. So here the level was greater than 1 nanogram per milliliters within 24 hours of starting exogenous progesterone. It should have cancelled the cycle, but the clinic went ahead and transferred at 144 hours. And the problem now is because the patient had already had a rise of progesterone before the exogenous progesterone was started. That transformation towards the secretory phase had already begun, so the receptivity was achieved more quickly. So instead of transferring to a receptive endometrium, we're actually now transferring to a post-receptive endometrium where there's probably no chance of implantation. So even though everything else has been kept the same, we've just changed that one variable, the patient's embryo is now wasted, which is a real shame. So another example here, this is where endogenous progesterone is not measured at all, and we do sometimes see this. So biopsy was performed at 120 hours, and we got a post-receptive result suggesting that the window of implantation was actually reached prior to biopsy being taken. So our usual recommendation is, in this case, is to perform another biopsy 24 hours sooner, so at 96 hours. But this case raises a few questions because progesterone was not measured. We don't really know if the patient really was post-receptive or was perhaps progesterone already elevated. So can we really trust this result? Are we going to make the patient go through another biopsy completely unnecessarily? And what happens if we do another biopsy and the two results don't correlate? Are we going to make the patient have a third biopsy? So it really is important to control that progesterone. So moving on now to talk about the cycle itself and how the conditions can affect reproducibility of ERA. So we'll be looking at the cycle type, but also cycle medications and additional medications. And again, the message here is keep everything the same between the mock and the transfer cycle. So in terms of cycle conditions, what does the protocol say? The protocol says that the result is valid for the cycle that ERA is performed in. So it's relevant only to that cycle type, which means that if you are planning to do a particular cycle type in the transfer cycle, you need to do the same cycle type in the mock cycle. ERA should only be performed in an HRT or a natural cycle, not a controlled ovarian stimulation cycle. And the reason for that is that you end up with really high and unnatural levels of hormones during a stimulation cycle, and it's hard to reproduce those conditions from cycle to cycle. So as well as the cycle type, we also want to be keeping the cycle medication, mode of administration and dosage the same as well. So when carrying out an HRT cycle, what do we need to keep in mind specifically? As you know, an HRT cycle involves both estrogen and progesterone. Usually a patient will start the estradiol therapy on the first or second day of the cycle, and then the ultrasound scan is performed 7 to 10 days later. It's important that you don't give more than 17 days of estradiol therapy, and that's because extended estradiol protocols have been linked to endometrial bleeding, and this can cause a non-informed TIP-0 result, so the patient not getting a conclusive answer, which can be really frustrating as a new cycle and a new biopsy is needed. Once the endometrial thickness reaches about 6 millimeters or more, as we said before, you then want to check your endogenous progesterone, that it's less than 1 nanogram per milliliters, and then within the next 24 hours start your first intake of exogenous progesterone. In terms of timescales, we consider the starting of exogenous progesterone P+0, and the biopsy is then taken 5 days later at P+5, and we want to keep the HRT treatment medications the same, so the mode of administration, the dosage, exactly the same for the MOC and the transfer cycle. What about if we're doing a natural cycle? In this case, we need a reference date for ovulation timing. If you're using an HCG trigger, which is generally the preferred option because it gives the most control, we would consider this HCG +0, and the biopsy would then be taken at HCG +7, so 7 days later. The other option is the LH surge, and if you're choosing that option, you would consider the LH surge as LH +0, and the biopsy would be taken 7 days later, LH +7. Again, you need to be controlling the endogenous progesterone, and needs to be less than 1 nanogram per ml at the HCG or LH surge, and again, we want everything to be the same between the MOC and the transfer cycle. So it's really important to note that the personalised embryo transfer recommendation, or the PET recommendation, is going to be based on this reference date, so HCG +0 or LH +0. So if we don't have that information, we would recommend cancelling the cycle. Lastly, a modified natural cycle. We would consider this to be either of the two natural cycles I've just mentioned, but adding in exogenous progesterone. So in this situation, we would, the reference date is still going to be the HCG trigger or LH surge, and the progesterone can then be started from LH +1 or HCG +1, whenever that's usually done, but never before the HCG trigger or the LH surge. And again, we want to keep the timing of this and the dose and mode of administration exactly the same between the MOC and the transfer cycle. Going back to our TRF, there's a space for you to add in the daily dose of exogenous progesterone and the mode of administration. And as I said before, this is really important for our lab team so that we can see the precise protocol that the patient's following, especially if more than one biopsy is coming in from the same patient. We need to know whether we can correlate those two results. So what can happen if the progesterone protocol is not replicated between the MOC and the transfer cycle? So you can see at the top here, we've got the MOC cycle, and the patient had 400 milligrams of vaginal progesterone twice daily. The biopsy was then taken at 120 hours. The result suggested that the patient was pre-receptive by 1 day, so window of implantation likely to be reached 24 hours later. So then we recommend an additional 24 hours of progesterone prior to transfer. So then moving to the transfer cycle, for some reason, IM progesterone was added to the protocol here. So the patient was having the same vaginal progesterone, but an extra dose from this IM progesterone. The transfer was done according to the recommendation at 144 hours, but because we've added in this extra progesterone here, the endometrium reached its receptive state a bit sooner at 120 hours. So by the time transfer was actually performed at 144 hours, the window had already closed, meaning there was very little or no chance of implantation. So just a small change in the progesterone protocol can have a really big impact for the patient. So are we able to correlate results from different MOC cycles? And you may find that our ERA team will contact you in certain situations to get more information about the protocol your patients have been on, particularly where patients had more than one MOC cycle. You might be asked to fill in a table a bit like this. And this helps us to understand whether the results from different cycles can be correlated. So was everything kept the same? This can be time consuming, but it's really helpful for our team and definitely leads to the best outcome for your patients. If there is a change in protocol between two different cycles, then we know we can't correlate the results from those cycles and we have to treat them independently. So in this case, the clinic was asked to fill in the table for two different MOC cycles, and you can see for cycle 1, the administration type of progesterone, exogenous progesterone, was different between the first and second cycle. So cycle 1, vaginal and IM progesterone, and cycle 2, just IM. And then we can see here the results from these cycles were different. Cycle 1, a late receptive result, and cycle 2, a receptive result. So in this situation, in the second result, there was a comment on the report to say that we have to treat these 2 cycles independently. So this is for the patient, and the clinic can waste time and money. So replicating everything is really important. So what about additional medication during a cycle? We know that some medications can affect the reproducibility of the ERA results. As we've already mentioned, one of those is the medication that you have during an ovarian stimulation cycle. What about other medications? We can't possibly know the effect of all medications. We'd have to try them all out, which we can't do that. So the most prudent recommendation is to just use estrogen and progesterone in your HRT cycles. We know that that's not always possible, and if you do need to take, if your patient does need to take additional medication, it's just really important that that medication, everything about it, the protocol is replicated between the MOC and the transfer cycle. And of course, it's important to note any medication that the patient is taking outside of the IVF treatment. So again, the message is the same, just try to keep everything the same. So what if it is necessary to change medication protocols? Ideally you don't, but we know that in some cases it can be, for example, if a patient has an allergic reaction or sensitivity to a particular type of progesterone. We would recommend in this situation to account for any shift in the window of implantation that might occur with a different protocol. We would recommend that you repeat the biopsy with the new progesterone protocol. There is an exception to this, and that's where you might want to adjust the estrogen protocol to ensure that the endometrial conditions are the same between cycles. So we know that, and we'll talk about this in a minute, but endometrial thickness can affect the reproducibility. So it is okay. For example, an example would be if in the MOC cycle you had a thickness of around 8 millimeters, but in the PET cycle the lining was only around 5 millimeters, it would be okay to have some additional days of estrogen or adjust the type or dose just to build a similar lining to the MOC cycle. So moving on now to talk about using the ERA result and how important it is to adhere to the recommendation you've been given. So this means transferring the embryo actually at the time that you were given from the MOC cycle result. And I'll illustrate this by giving you an example of what can happen if you don't follow that recommendation. So we've got the MOC cycle at the top here, and it's an HRT cycle, biopsy taken at 120 hours, and the result was pre-receptive 1 day, which means at the time of biopsy, the endometrium was about a day away from being receptive. So the recommendation here for the PET cycle is to transfer a day, 24 hours later. So hopefully this is when the endometrium achieves that optimal receptivity. And we've got the transfer cycle here, and for whatever reason, the patient had an extra day of progesterone above what ERA recommended, and the transfer took place at 168 hours, by which time the window of implantation has closed. So we know that this does happen, even though we're clear on the reports of what the recommendation is. So a couple of possible reasons for this. Firstly, it could just be an error in calculating the timing. It's difficult sometimes when dealing in hours. It could be patient error. Some patients are going through IVF for the first time, and it can be overwhelming understanding which medication to take and when. Or it could be a scheduling error. So we know that usually after an HRT cycle, transfer would be 5 days later. So it could just be that the clinic go onto autopilot. We can help with this, and I will touch on that in a minute, but we've got a really useful tool that can help with calculating the exact time for your transfer. So lastly, just moving on to the some patient and uterine based factors that can influence reproducibility of ERA. If we start with BMI, so this is a major shift in BMI between the MOC and transfer cycle. So as Laura indicated, ERA is suited for patients with repeated implantation failure, but we know that other groups, there's evidence that other groups may also benefit. I mean, patients with a increased BMI, so BMI over 30, are at a greater risk of having a displaced window of implantation. So ERA is something that can help those patients. So if there is a change in BMI, we know that the endometrium is hormonally regulated. If there's a change in BMI, this can alter how hormones are metabolized, and it can affect the window of implantation. So if you do have a major shift in BMI between the MOC and the transfer cycle, for example, moving from above 30 to below 30, we would recommend repeating ERA to account for any shift in the window of implantation that might occur. So generally ERA results are applicable for 36 months, but if there is this big shift in BMI, we would recommend repeating the test. So what about uterine interventions? An example would be if a patient is going to have a polyp removed prior to transfer. This type of intervention can affect the window of implantation, so we would generally recommend that it's done before the ERA MOC cycle. We want the endometrium to be in the same conditions for the MOC and the transfer cycle. So if you do happen to do the MOC cycle first and then the procedure, we would recommend considering whether you actually need to repeat that MOC cycle so that the results can be reproducible. And then finally, moving on to our last factor that affects reproducibility, endometrial thickness. So we've touched on this very briefly. Patients with endometrial atrophy, so a thickness less than 6 millimeters, are another group who are at increased risk of having a displaced window of implantation. So another group that can benefit from ERA. One of these studies that illustrates this is some data that we presented at ESHRE looking at endometrial receptivity according to 3 different thicknesses of the endometrium. So atrophic, which is less than 6 millimeters, and normal endometrium, which is between 6 and 12, and a hypertrophic endometrium, which is more than 12 millimeters. And we found that the atrophic endometrium, excuse me, less than 6 millimeters was associated with a significantly higher rate of a displaced window of implantation compared with the other 2 groups. So in order to ensure reproducibility, we recommend that the endometrial thickness should be in the same range for both the MOC and the PET cycle. And these 3 ranges are, as illustrated on the previous slide, less than 6, 6 to 12, and more than 12 millimeters. So if there's a shift between these 3 ranges, between the MOC and transfer cycle, we recommend cancelling the transfer cycle because that shift could impact the window of implantation. Excuse me. Again, just going back to the TRF, there is space to insert the endometrial thickness, and that's really helpful for our lab team when we know, particularly where more than one biopsy is done and we're looking to correlate those results. So I hope that's been helpful in summarising the factors that can affect reproducibility. In conclusion, complying with the protocol is really important to get the best outcomes for your patients. If we do this, if we keep the variables the same, we're going to hopefully get the best outcomes. If we don't and we change variables, this can lead to unnecessary additional biopsies, cost and delays for the patient, as well as that emotional burden of a failed transfer and wasting embryos. The good news is that we can help you to comply with the protocol. So we've got 2 really useful tools. Firstly, the personal embryo transfer calculator, which helps you to ensure that you follow the recommended PET timing. So I'll very quickly go through this. I know that we're conscious of time. You would firstly indicate your cycle type, then select the type of embryo for transfer. You can also use this for timing biopsy cycles. You then indicate the number of hours after starting progesterone which the ERA report recommends transfer. And then you can pick either the day of progesterone start or the transfer date. Usually easier to pick the transfer date because that's the date that there are more constraints on for scheduling. So we've picked a date here, the 27th of June at 9 AM. And then click on calculate, and you should be given when the patient needs to have their first intake of progesterone. So hopefully this is something that's really going to help clinics and remove room for error. The second tool we have is the ERA Clinic tool, which is downloadable, and this has 3 columns. The first has the factors that affect the reproducibility of ERA. The second column is for their MOC cycle, and the third for the transfer cycle. So a tool that both clinics and patients can use, and it's good to have patients taking some responsibility as well. So both of these tools can be found on the ERA Hub. This is the web address. It can be linked through our website as well. And this is a really useful resource. We've got videos from experts and scientific advisors. We've also got previous webinar recordings, some publications, and a link to be able to sign up to our pre and post test webinars. So hopefully that's given you some good insight into why complying with the protocol is important, and I will hand over now.
Thank you, Lizzie, and feel free to mute and cough till your heart's content. Bless you. Thank you for struggling on there. Got me at it now. So we will go to the question and answer section. there have been quite a few questions, so we'll start and we'll see how far we can get through. So the first question for the panel: how long is the ERA test valid for, and in which cases do I need to repeat it?
Shall I take that one? It's valid for 36 months, but that is providing that everything is kept the same. So the cycle conditions, the endometrial thickness and the BMI. If anything changes, then we recommend that the ERA is repeated.
Okay, perfect, nice and simple. Moving on. Can I perform ERA in a controlled ovarian stimulation cycle?
No, it's only valid for an HRT or a natural cycle, just because the conditions during a controlled ovarian stimulation cycle, it's hard to reproduce those from cycle to cycle.
Okay, perfect. This one's a good one, and one that's quite interesting. Planning to transfer a day 3 embryo, does this change the ERA report recommendation? I think that's something I've been asked in the past by customers as well.
So yes, you would need to transfer 2 days earlier for a day 3 embryo, and that's something that the PET calculator would be able to do for you. So if you were using the PET calculator, you would put the usual ERA recommendation in, and when you'd indicate that you're transferring a day 3 embryo, and it would automatically calculate that for you.
Okay, so again, a good tool to use. Here we go. Can I perform the biopsy collection during a hysteroscopy?
Yes, I think the recommendation is to do it at the beginning of the procedure if you're going to do that.
When to start progesterone supplementation in a natural cycle?
In a natural cycle, you would start from HCG +1 or LH +1, and whatever is kind of normal practice for your clinic, and just as long as you do the same thing in the mock and the transfer cycle.
I feel like I'm firing these at you, Lizzie. Sorry. Is ERA valid after pregnancy and or miscarriage?
There isn't any clear evidence about the impact of birth or miscarriage on the window of implantation. Sometimes it seems to change, sometimes it seems to stay the same, but when it does change, we're not sure whether that's caused by the birth or the miscarriage or other factors. So I think probably the best recommendation, I don't know if you would agree, Maria, is probably to do another ERA before moving forward.
Okay, perfect. If endogenous progesterone was not recorded, or if it was recorded but is greater than 1 milligram per milliliter, would you still test the sample?
If it wasn't recorded, I think our support team would go back to the clinic and see if they could get the value. Perhaps they just forgot to put it on the TRF. If it wasn't, if they didn't record it at all, then they could still process the sample, but it would be hard to rule out the results weren't affected by raised endogenous progesterone. So there would be a comment on the report to that effect. And if it was measured but it was greater than 1, we would recommend cancelling the analysis and repeating.
And what is your turnaround time?
It is 10 working days.
Okay, 10 working days from
receipt of the sample in the laboratory.
Okay, perfect. Those are all the questions that I can see from the question chat box. I'm just seeing if there's any hands raised. I can see someone is typing a question, but I think that is all for now. So if there are any further questions, please contact the team and we will reach out and answer. Oh, I've just seen one now, sorry. Do you recommend P4 on day of embryo transfer? What P4 would you expect on day of embryo transfer?
I think that might be one for Maria.
Yes, we have analyzed if there are any relation between the progesterone levels on the day of the biopsy and the ERA results, and there are no correlation. So we are not looking for a specific value on the day on the embryo transfer or on the day on the biopsy collection, but this could be relevant for the pregnancy support. So some clinicians are looking for having more than 10 nanograms per milliliter the day of the embryo transfer or the day before, and if they don't have these levels, they increase the dose of progesterone. So what we do, or what we recommend is, we are not going to recommend to increase or not, because for us, for the endometrial receptivity acquisition, this is not important. But in case that you want to do it to support the pregnancy, then our recommendation is to increase the dose of progesterone always 24 hours after the blastocyst transfer, because any modification, as you have learned in the previous presentations, any modification on the dose of progesterone can alter or modify the endometrial answer. So we are not looking for a specific value. We don't need a specific value of progesterone on the day of the transfer or on the day of the biopsy. But if you are looking for that because you have like a cutoff or something and you're going to increase progesterone, always do it 24 hours after blastocyst transfer. Our only recommendation regarding progesterone levels is prior starting the exogenous progesterone intake. That has to be less than 1 nanogram per milliliter. After that, we are not looking any specific value.
Okay, perfect. I think that is the last one, folks. So once again, I thank you to all the panelists and everyone for attending. And I will say again, if there are any questions that you have, please reach out to the account manager that you have or the team here, and we will be happy to help. And I hope everyone has a great afternoon. Bye, everyone.